Our next speaker is Dr. Marc de Perrot. Dr. de Perrot is an associate professor of surgery and the Division of Thoracic Surgery at the University Health Network. Dr. de Perrot obtained his medical degree and completed his surgical residency at the University of Geneva in Switzerland. He then completed a fellowship in thoracic surgery at the University of Toronto and the University of Paris in France. In 2005, he joined the Division of Thoracic Surgery as a staff surgeon, where he currently directs the mesothelioma research program. He's involved in basic and translational science research, looking at new treatments with immunotherapy and combined modality therapy. Dr. de Perrot.
Thank you for the invitation, and good morning, everyone. So I will present you a little of an overview at what we are doing in the lab. And what I'd like to highlight is really the key part as a clinician is to be able to bring into the lab what you're observing in the clinic and then to understand what you're doing and then bring it back to the clinic. And that really directly applies to mesothelioma. And more it applies to immunotherapy as well. As you will see, there's a lot of new molecules, and you cannot just trial them all in clinical trials, but you have to understand how they interact together and how they can work with current treatment. So just a brief overview about mesothelioma. So it's related to asbestos exposure, and as you've probably heard, asbestos has been controlled for 20, 30 years in Canada, but it was only banned last December. And industrialized countries are currently in the midst of an epidemic of mesothelioma. There are currently over 500 new patients diagnosed with the disease every year in Canada. And the tumor is associated with very poor survival despite aggressive treatment. This is the type of survival that we observe with mesothelioma. Patients with a diagnosis of mesothelioma survive 6 to 12 months after their diagnosis, despite different type of treatment. So we've had a number of studies at Princess Margaret on Toronto General to try to improve on the treatment. And one of the studies was to give them chemotherapy, surgery, and radiation. And that was started in the early 2000s. And when we look back at our results in 2008, we observed that patients who had radiation after the surgery and without any nodal disease actually tended to do better than the other patients. So we thought that radiation was actually a good way to treat these patients, and we developed a new trial to give the radiation before the surgery in order to improve on the quality of the radiation. But one thing that we changed is the type of radiation. Instead of giving radiation every day for 5 weeks, we gave it in 5 days. So a higher dose with a shorter course, which allowed us to do it before the surgery, but also, as you will see, actually impact on the immune system. So with that type of treatment, we were able to improve on the survival. And then we, in parallel, went to the lab to try to understand why we were able to improve the survival. And over the past few years, there has been increasing evidence that the radiation works on the immune system. So for a long time, the radiation was thought to work on damaging the DNA, on creating a lot of stress within the cell, and eventually the tumoral cell will die because of the radiation and the effect on the DNA. But there's also a part of the radiation that activates the immune system, and this is particularly true when you give a short course of high-dose radiation, which is what we've been doing with the new trial. So we went into the mice in order to try to understand how that was working between the radiation and the immune system. So in the lab, we have 3 different types of models with the mice. We have the xenograph model, where you take a piece of the tumor from the patients, you inject it into an immunosuppressed mice, and you can see how it works. So you can look at the different clinical or biological or genetic parameter of the tumor itself. The problem is that the mice lacks any type of immune system, so you cannot really study the immune system that is reacting against the tumor. Then we have a spontaneous model. You inject the asbestos to the mice, and you let the asbestos takes effect on eventually a number of mice will develop mesothelioma in the course of their exposure, but that takes several months. Not all mice develop mesothelioma, but only 10 to 20%. So it's a very labor-intensive type of work. or not very practical. And then the last type of model that we've been using mostly is the syngeneic model. These are immunocompetent mice that were injected with asbestos in the past, and then they developed mesothelioma. And out of these mesothelioma, cell lines of mesothelioma were created. So these are mice mesothelioma cell lines that genetically are very similar to the human mesothelioma cell line that have also been created. So we went into the mice using the syngeneic model, and if you take a cell line and you inject it in the pleural space, the tumor develops and creates a situation that is quite similar to patients. And this happens within a month or so. So you can inject the cell lines into the pleural cavity, into the peritoneal cavity, or subcutaneously, according to the type of experiments you want to do. So this is in the pleural space, so you can see the lungs, the heart, and the development of the tumor along the pleura on the pleural effusion that reproduce again the clinical scenario. So we went into the mice and developed some type of radiation therapy against the tumor. We took the subcutaneous model, which was easier to use for that. And then we delivered the radiation. We used different type of radiation. This is the normal progression of the tumor subcutaneously without radiation. And then we use different type of radiation, and we can see that there was an effect, and eventually the tumor started to rise again. And we took eventually 3 times 5 gray, which was very similar to what we are doing clinically, and also the mice tolerated that quite well, so did not get sick with the radiation. But what we observed was that the radiation created a very active immune activation, and you can see that after 7 days and 12 days, you have a very dramatic rise in the T-cell infiltration of the tumor that you don't see if you don't treat the mice. And so we characterize this T-cell, and we use a cell line with that was expressing of albumin, which can be used as a tumor antigen. And you can see that this T-cell, and in particular the CD8 T-cell, reacts against ovalbumin after the radiation. So the radiation triggers an inflammatory reaction that is specifically activated against some of the tumor antigen ovalbumin here. And then we depleted the mice. So you take the mice, you radiate them, and then mice were, so you can see the no radiation treatment and the radiation treatment here. And if you deplete the mice in CD4 and CD8 T cells, the effect of the radiation is decreased by about half. So there's still an effect of the radiation, which is probably a direct effect of the radiation on the DNA of the tumor cells, but you lose a lot of the benefit from the radiation. And if you deplete CD8 T cells, you lose part of the benefit. And interestingly, if you deplete CD4 T cells, you actually improve on the benefit of the radiation. And part of that is due to the fact that some of the CD4 T cells are Treg cells, which actually are anti-inflammatory and protect the tumors. So then there is a number of molecules that have been developed over the past few years, and a large number of them are in clinical trials, and they were tested initially in melanoma, shown to work, and now they're tested in multiple types of tumors, including mesothelioma. The problem is these are the 3 main molecules that have been targeted, but T cells on the tumor, on the macrophage, on the dendritic cells express a lot of molecules. And so you have an increasing number of molecules that you can target, and you cannot do clinical trials on all of them, and you cannot combine them in clinical trial. You have to really understand how they work in order to optimize their potential benefit, and that's where the translational research really does help a lot to speed up the process. So one of the studies we did was to combine radiation with the CTLA-4 blockade. So we gave the radiation and then CTLA-4, and we had a group with radiation alone and a group with CTLA-4 alone. And then we treated the first tumor, and we injected the second tumor on the other flank of the mice to see what was the systemic effect of that treatment. So the first tumor was the radiated tumor, and you can see that if you give CTLA-4 alone, there is minimal benefit. If you give radiation, the tumor grows slower, as you were expecting. This is 1 week after the start of the radiation. And if you combine radiation and CTLA-4, you get an improved benefit on the primary tumor related to the addition of CTLA-4 blockade. Then interestingly, if you inject the second tumor after the treatment, the mice that had the radiation, the second tumor grew slower. And then the mice that were treated with radiation and CTLA-4 inhibitor the tumor of the second injection grew even slower, and about a third of these mice rejected the tumor. So the effect of the radiation appears to be more systemic than localized, which again relate to the immune system. And then we did the same experiment in immunosuppressed mice, and that effect was gone. And one of the benefits of CTLA-4 is to deplete the regular T cells, so these CD4 T cells that are anti-inflammatory, that are upregulated with the radiation. Giving the CTLA-4, you actually prevent that upregulation of CD4 regulatory T cells, and that's how the CTLA-4 probably benefit when it is associated with the radiation in the primary tumor or the secondary tumor. And then we also developed the surgery. Since our protocol involved radiation and surgery, we wanted to see what was the effect of the radiation in combination with surgery. So we developed two types of surgery: inject the mice subcutaneously, and then you remove just the tumor, leaving the edge of the tumor in place, what we call an R1 resection, so it's not a complete resection. And then a radical surgery where you resect the whole tumor with healthy tissue around it. So if you resect only part of the tumor grows back. If you give the radiation, as I've shown before, you have similar results as before. And then if you combine the two, the tumor does grow back, but at a slower rate than if you do the surgery alone. And actually, the growth rate of the tumor after the surgery is faster than the no treatment group. So surgery actually probably activates the growth of the tumor because of the anti-inflammatory effect of the surgery during the healing process. And then we did another study that was quite interesting with radiation and radical surgery. So you inject the mice, and then you do surgery with a radical surgery. So almost all the mice are cured. And then you do radiation and then surgery the following day. And then we did the 3 days of radiation, and then waited a week before doing the surgery. So the vast majority of these mice were cured. And then we waited 3 months and re-injected the mice with a similar cell line on the other side. And what we observed is that the mice that were treated with surgery alone, or radiation and surgery within 24 hours, the second tumor after 3 months grew very quickly as it was the first time. But the mice that were treated with the radiation on a week before the surgery, actually a third of them rejected the tumor. So they developed some memory immune response that prevented the tumor from growing. And the tumor that grew much slower than in the other mice. So there was a long-lasting immunological benefit from the radiation. And then if you deplete the CD4, CD8 T cells, you can see that you lose that immune protection. And interestingly, if you deplete only the CD8, the mice still kept that immune protection, while if you deplete the CD4 alone, the immune protection was gone, but the mice still grew relatively slowly because the CD8 was still protecting them. So this is a bit of an overview, but just to show you that radical radiation does work potentially in mesothelioma. And that from our mice model, we can understand that the radiation does work by activating the immune system with particularly the CD4, CD8 T cells within the tumor, that the upregulation of the regulatory T cell after the radiation prevents the radiation to be optimal, and you can optimize the radiation by using CTLA-4 with radiation. And in the long term, the benefit is mostly related to CD4 T cell rather than the CD8 T cell. So this work was done by a lot of people, and again, this is just a fraction of what we've been doing over the past 12 years. But we have Lincoln Wu, who is our research associate in the lab, who does a lot of the work and supervises a lot of our students. Yidan Zhao, also in the lab as a research associate, who works a bit more on the pulmonary hypertension side, the technician Hannah. And then current fellows in our lab, Mickey, Ro, James, and Yan. And we have a large number of previous fellows, including some who did a Master of Science, Masaki, Louis, and Matthew. And then Olaf Mercier, Tetsuzo Tagawa, and Isabel Opitz were in the lab and went back to Japan, Paris, and Switzerland. And we have a number of collaborations within UHN in Switzerland and in New York as well. Thank you.